Hi everyone, this is Professor Widener going over Chapter 3, Hemopoietic Function, which is basically talking about the blood and all the different components of it and disorders of it. Good evening or good morning whenever you're actually listening to this. We're going to go ahead and get started. So blood is the life fluid of the human body. It is essential for health and hemostasis. We cannot live without blood. I want you to picture in your head a patient you may have taken that was anemic and how they don't feel well. They get dizzy, they get short of breath. There is, their heart rate can go high, all in response to this lack of blood. So it's very important and critical to our functioning as human beings. There's approximately 5 liters of blood in the body, and its job is to provide nutrients and oxygen to the tissues, and then it also aids in the excretion of waste products, as it works in conjunction with the kidneys and the liver to excrete waste, and also takes out the carbon dioxide. It consists of a few different components. There's plasma, blood cells, and platelets. The plasma carries blood cells as well as the antibodies, nutrients, electrolytes, hormones, lipids, waste products, all around the body. It is the most abundant protein with albumin, and it helps to maintain osmotic pressure in the blood vessels. We'll talk about some of the blood cells, and the first one we have is the leukocytes. We know that they are released from inflammatory or infectious response. Erythrocytes are disc-shaped cells, and their job is to carry oxygen to the tissues and transport CO2 out of the tissues for removal. Thrombocytes are coagulation factors that control the clotting cascade. And plasmin is an enzyme that dissolves clots once the healing has occurred. Diseases can occur in the blood when there's too many red blood cells, when there's too few blood cells, or they're dysfunctional. And that's similar to the blood components. If there's not enough of one or too much of another, that can present some problems. And these issues can be congenital, genetic, or environmental, or iterogenic, which basically means we don't have any idea why it happens, but it does. Talking a little bit more about this blood specifically, it's a viscous fluid, and it's interesting, I think, that it's a connective tissue, again, because it's doing so many different functions. And then that's the breakdown, the plasma, the leukocytes, erythrocytes, and thrombocytes that we just talked about. That's the different breakdown of that. Hemopoiesis is the formation of blood. It occurs in the bone marrow, and it requires a steady supply of hemopoietic stem cells. These stem cells differentiate into different kinds of blood. These stem cells are considered multipotent cells. That's because they can transform into so many different kinds of cells. Red blood cell production is stimulated by hypoxia and blood loss. It's also stimulated by erythropoietin, or EPO. EPO is produced in the kidneys in response to in response to poor oxygenation. EPO is essential for erythropoiesis as it signals the cells to continue to develop these precursor cells. Synthetic EPO can be used in patients with who have undergone chemotherapy or have chronic kidney disease, because their EPO it's produced in the kidneys, and when they're not functioning up to normal levels, you'll often see that someone may have anemia of chronic kidney disease, and we can give them blood if it's a temporary fix, but it will ultimately not bring their blood count any higher. So that's why we give them the EPO to stimulate their bone marrow. There is also iron, which is the heme portion of the red blood cell development, And the dietary sources of that include animal proteins, plant proteins, and dairy products. Hepcidin is the regulatory role for iron uptake and transport, and there is a lovely diagram on page 82, figure 3.5, that reviews oxygen, iron absorption. I think that would be very helpful. Hemostasis is the process by which the bleeding is stopped. There's a primary and a secondary mechanism for this. When there is decreasing blood loss, there's a series of events that happen with the endothelium and vasoconstriction. So hemostasis is the coagulation process that's limited to the area of injury. Normal hemostasis requires endothelial lining integrity and platelets. So when a blood vessel is injured, there's a decreased blood supply. This stimulates the endothelial cells to reflexively start constricting the blood vessels. The platelets are then blocked from adhering to the cell membranes by nitric oxide and prostaglandin. Past injury, so the things that normally inhibit platelet aggregation are decreased. That way, the platelets can adhere to the area where there is the area of injury. Next, the endothelial lining cells secrete von Willebrand's factor, which binds to the platelets and creates the glue that holds the platelets together at the area of injury. The platelets then release fibrinogen and calcium, which are necessary for secondary hemostasis, and they combine to form the platelet plug. Overall, the platelet plug is weak. However, it is strengthened by the fibrin circulating in the blood as fibrinogen. Fibrinogen becomes fibrin with activating of the clotting cascade with thrombin and other key mediators, and this is secondary hemostasis. We're going to keep talking about the clotting cascade. So once the clotting factors lead to activation of another, that's called the clotting cascade. So now we know how the platelet plug is formed. The platelet plug has phospholipid surface that inactivates the precursor that inactivates thrombin to become active thrombin. When the calcium is released by the platelets, that activation is necessary for coagulation factors 2, 7, 9, and 10 to be activated. Vitamin K is made in the liver, and that produces the precursors to those factors. So when you're thinking about, as we're going through the clotting cascade, I want you to think about where Coumadin would work, since it's a vitamin, it inhibits vitamin K production. I want you to think about where the direct thrombin inhibitors might work. So knowing the clotting cascade is important for when you're anticoagulating your patient as well. On page 85, figure 3.7, if you look at that while you're listening to me lecture, that may be helpful. The intrinsic and extrinsic pathways. There's two pathways, the intrinsic and the extrinsic. Injured blood vessels trigger the extrinsic pathway factor, which activates factor 7, which then activates factor 10. Then that leads to thrombin activation. Thrombin then activates going back up by activating factor 11, 8, 5, and 7. All fibrinogen becomes fibrin. The fibrin strands attach to the platelet plug, which is factor 8, resulting in fibrin meshed clot. Once the fibrin mesh clot is there, the whole clot is formed. The clot is then dissolved via fibrinolytic system when inactive plasmagen becomes active plasmin to dissolve that clot naturally. So that is the spot where if you're in the hospital and you see someone given TPA for a stroke or a myocardial infarction, they are having the body speed up the fibrinolytic system to dissolve that clot. Because remember, the body sees, we're talking about a blood vessel injury right now, but remember, the body sees anything as a foreign substance. They're trying to get it out of the system. So when somebody has a stroke, and 90% of strokes are caused by having plaque in the brain, the body sees that plaque just like it sees an injury to the blood vessel. So we so when the blood vessels clogged a little bit by that, you see that it gives off these inflammatory responses that it calls all these clotting factors and everybody over to help try and get rid of that. And that's actually what causes the stroke, because the clot is formed by the natural clotting process of the body trying to get rid of that piece of plaque, which is why we give people aspirin, because again, it makes the platelets not as sticky, so they just keep cruising on by and don't say hi to the piece of plaque in the brain. The other thing is that we also give people statins because we know that statins decrease the inflammatory signals from that piece of plaque. So this really has a lot of implications. It's kind of cool when you can start to put it all together. So the lymphoid system is the organs connecting the hematological and the immune systems. The thymus is the site of B cell maturation. The bone marrow is the site of hemopoiesis, and the spleen is the blood filter. The lymph nodes protect against infection. Also part of this is the tonsils and the adenoids. And I just think it's important because again, you'll see, we see tonsils and adenoids removed at times, and their job is actually to trap microorganisms that either enter the mouth or the nose. Although they can be removed if there's too much collection of these microorganisms that are causing problems. Next, we're going to talk about diseases of the white blood cells. So my suggestion would be, once you go through the lectures, just make like a chart almost for yourself that has the different diseases of the white blood cells, the different anemias. Once you understand the basic pathophysiology that we just went over, all the rest of this will make a little bit more sense. So just try and look at it so you'll be able to apply it to test questions when you see patients. So normal white blood cell count is between 5,000 to 10,000. Leukocytosis is when there's an increase in the white blood cells, and leukopenia is when there is deficiency in the white blood cells, and that is caused by bone marrow suppression. And you might see that during when someone has chemotherapy, and you may also see it in the initial stages of sepsis. Leukocytes' job is to trigger the inflammatory process and combat infections. They originate from deficiencies of the leukocytes. Basically, their job is to just head on over to the site of injury and help out, and see their job is, to see what they can do to help out. Neutrophils are the first responders to infection or inflammation. Neutrophils phagocytize microorganisms and then the infection dies. Remember, phagocytize is kind of like, think like a Pac-Man, they just kind of eat it up. The leukemoid reaction demand is when demand is higher than supply bone marrow offers to release immature blood cells. So when there's a leukemoid reaction, basically more immature cells are released than need be. So you might see that like in a leukemia, which we're going to talk about in a little bit. Neutropenia is the decreased ability to fight infections, and that is when your white blood cell count is less than 15,000. This lowers the body's ability to fight infections, and there are multiple causes of this. And the possible causes include severe infection, aplastic anemia, leukemia, bone marrow suppression from chemotherapy, radiation, immunosuppression, or low vitamin B12. The clinical manifestations of neutrophilia is basically you get an infection of some type. It can be bacterial, fungal, or viral. Remember, it does not only include the bacterial, but it does include the viral infections as well. It is dependent basically on the cause. Some of the signs and symptoms include what you might see with someone who has an infection, such as fevers, chills, or malaise. The respiratory tract is the most common site of infections. And the way to diagnose it, obviously, is to check a CBC, which is where we'll find the neutrophil levels. And then treatment depends on basically treating the underlying cause. And if there ever was a time for a lot of these disorders, and you can't go wrong with this answer, but if you ever look at like diagnosis, CBC is going to be the answer for a lot of them. And the other thing is that if we know someone has a high or low neutrophil level, but we can't figure out why, we would send them for a bone marrow biopsy to get the diagnosis. So that would be our mechanism for that. Eosinophils and basophils, again, they are part of the CBC differential. They are lower in number than the neutrophils. The eosinophils control and augment the inflammatory response. They can be elevated in parasitic infections and also with malignancy. Basophils release histamine and mediators, and they occur during the hypersensitivity reactions, and specifically the immediate hypersensitivity reactions. As far as lymphocytes and monocytes, lymphocytes are more likely to be elevated when there is a virus. It is again a key cell in the immune response. Lymphocytosis is when the white blood cell count is high, and lymphopenia is when it is low. High lymphocytes can mean hepatitis, herpes, CMV, or some kind of bacterial infection, or lymphocytic chemotherapy, or lymphoma. When the lymphocytes are low, that can indicate an immunodeficiency, AIDS, or HIV, or destruction from some type of chemotherapy or radiation. We're going to start going through talking about the lymphomas. Hodgkin's is going to be the first ones. The lymphomas occur from malignant lymphocytes in the lymphoid tissue. This is the most common kind of blood cancer, and it spreads via the lymph system. There are two subtypes of Hodgkin's lymphoma. There's Hodgkin's lymphoma and non-Hodgkin's lymphoma. In classic Hodgkin's lymphoma cases, you'll see the Reed-Steinberg cells, and I'm telling you, this is a question on every single certification exam. So remember the Reed-Steinberg cells and Hodgkin's lymphoma. But that is when there is an abnormal type of B lymphocytes that is much larger than the lymphocytes. And what they do is attract other cells to become part of the neoplasm. It's an overproduction of these cells. The Incidence rate, when you look at the types of Hodgkin's lymphoma and lymphoma, Hodgkin's lymphoma is accounts for 90% of 95% of the cases. It is classic um, between the ages of 20 to 40, and another peak time for this is over 55. Mortality rate has significantly improved over the last 25 years as we've developed and improved our chemotherapy. So as far as the clinical manifestations, you may see enlarged lymph nodes in the axilla or inguinal areas. They are usually painless. And when we start talking about lymph nodes, you'll learn that these lymph nodes generally don't move when you try to feel them. There may be a mediastinal mass on chest x-ray that's causing cough, difficulty breathing, or retrosternal chest pain, and that's the second most common finding. And then the other thing that I'll say this a few times, but they develop B symptoms, which is a persistent nighttime fever, nighttime sweating, and unexplained weight loss. So know that those three things make up the B symptoms, because we'll say that a few times throughout the course of the lecture. So the diagnosis is basically you have to biopsy one of these lymph nodes, and that also allows for staging. The other way we can stage is by using a CAT scan, MRI, and biopsy to see if it has spread anywhere else. The diagnosis the diagnostic things that would be important would be a bone marrow biopsy, a physical exam, a CBC, and a chest x-ray. Treatment includes chemotherapy, radiation, bone marrow, or bone stem treatment, and the cure rate is around 75%. Non-Hodgkin's lymphoma is basically the other kind. It is more common in middle age and obese adults. Non-Hodgkin's malignancies are derived from mature B cells or T cells or their precursors. There are a few subtypes. There's Burkitt lymphoma, lymphoblastic lymphoma, and large cell lymphoma. And there is a very nice table on page 91, table 3.2, that you can look at to review all those a little bit more and their differences. It's easier to look at them than me just read you the table. But some of the risk factors include presence of an inherited immune or autoimmune condition, infection exposure to H. pylori, toxins such as pesticide and hair dyes, obesity, and inflammatory gastroenterology conditions such as Crohn's or celiac. This is typically a fast-growing lymphoma and includes the large B cells. It usually presents acutely and with B symptoms, and without treatment, death can usually occur within a few weeks. These patients present with lymphadenopathy, hepatomegaly, and splenomegaly. They will also complain of anorexia, nausea and vomiting, and weight loss. And non-Hodgkin's lymphoma involves more lymph nodes throughout the body, and there's also more likely to have metastasis be present. Diagnosis and treatment is similar to what we would do for Hodgkin's lymphoma. Again, we're going to go back to the tried and true bone marrow biopsy, a physical exam, a CBC, and a chest x-ray. And then staging would be done by a CT scan, also known as a PET scan, MRI, or other biopsies. The prognosis is generally worse than it is with Hodgkin's lymphoma, and treatments again include chemotherapy, radiation, immunotherapy, or some kind of combination of those factors. Oh, sorry about that. I forgot to advance the slide. This just goes over the non-Hodgkin's lymphoma that we just talked about. The next disease we're going to talk about is multiple myeloma. This is a disease of the plasma cells, and it is basically when there's an abnormal response of the plasma cells to antigen. It generally affects older adults and originates from B cells. Multiple myeloma is actually classified as a type of non-Hodgkin's lymphoma and is the third most common type. In multiple myeloma, normal plasma cells begin to respond abnormally to antigens. These cells overproduce abnormal immunoglobulins that are intact or in fragments. It usually is IgG. When these come out, the body doesn't make as many osteoblasts, so these patients often come in complaining of bone pain. Their bones are thin and they are more prone to fractures. The bone breakdown causes the calcium to be released, so these patients also have high calcium. So when you have a patient who comes in with high calcium, it's important to just kind of put this on your differential. A lot of times if they're dehydrated or septic or something like that, it may just be situational. But if that calcium doesn't improve over a few days, that's something that you'll need to do as part of a workup. In multiple myeloma, plasma cells also produce free light chains, which are filtered through the kidney. So you can see in the urine Bence-Jones proteins. They are more prone to infection given the immunosuppression of the normal B cells. Because you can see these light chains, often when you're diagnosing multiple myeloma, you will do a urine serum electrophoresis. Sometimes you'll see it as a UPEP, UPEP, and what they're looking for are these free light chains in these specific Bence-Jones proteins. The clinical manifestations of multiple myeloma can be remembered by the mnemonic CRAB, which refers to calcemia, hypercalcemia, renal failure, anemia, and bone lesions. Usually at the time of diagnosis, and by the time they have symptoms, it is pretty well advanced. These folks will have signs of neuromuscular dysfunction from the hypercalcemia. They will also have typical signs of anemia and renal failure, which include fatigue, pallor, dyspnea, poor activity tolerance. You may see lytic lesions on chest x-ray. They are also prone to infection in the lungs and urinary tract. And this is also the other thing where you can look is called an SPEP. It's a blood work in SPEP. That's a serum protein electrophoresis that will analyze for the monoclonal proteins that are present in multiple myeloma. Treatment improves, and sometimes they can get people to remission. Overall, it is not curable. The treatments include treating bone pain, which is usually needs to be done with a narcotic. You want to treat the high calcium and the renal impairment. They generally are treated with chemotherapy and sometimes the new immuno agents, but mean survival range is 3 years. You may have heard myelodysplastic syndrome, or MDS. That is a group of hemopoietic neoplasms. It results in abnormal cell growth, differentiation, and maturation. These occur generally in people over 40 with the mean age being 72. It comes on from years of mutation, and they're often occur. Basically, these mutations come about because people are older and the exposures that they've been exposed to over the course of their lifetime. Clinical manifestations of these syndromes. Most times they're asymptomatic. Sometimes they may present to you with general arthralgias, bone pain, weight loss, or anorexia. They could have symptoms of anemia, shortness of breath. They could also have some thrombocytopenia, which makes them more prone to bleeding or bruising, and also decreased neutrophils, which makes them prone to infection. You would again diagnose this by history and physical, and also by bone marrow biopsy and CBC. This is treated by observation and supportive care. You would give people transfusion as needed. Uh, they might take EPO-stimulating agents as well. They might get chemotherapy or a stem cell transplant. You'll see a lot of these are different syndromes, and they have a little bit different pathophysiology, but a lot of them have the same treatment plans, diagnosis plans, and symptoms that make them a little bit kind of not so overwhelming. So focus on the ones that are different. Next, we're going to talk a little bit about the leukemias. And there is an application box 3.2 where you can match the different kinds of cancers. It's an activity that you can match up, and it's just good practice to look at, practice your skills with those. So I would suggest you do that activity. So with leukemia, bone marrow stem cells make abnormal leukocytes or leukopenic cells that travel through the vascular system, affecting different organs. These last longer than normal leukocytes, so they tend to get, the blood tends to get crowded, and it makes it difficult for the new red blood cells and the normal red blood cells to function, just because there's not enough room for them. The exact cause is mostly unknown. It is the ninth most common cancer in children. We think that exposure to chemicals, viruses, radiation, mutations, smoking, or use of chemotherapy can increase your chances of getting this. There are two kinds of leukemia. Well, there are four kinds, but it's either acute leukemia or chronic leukemia. They are named according to their cell lines and whether they're acute or chronic, and you can see the four different ones listed there. Acute leukemia has a more rapid onset and progression, and chronic leukemia has an insidious onset and is also less aggressive. When we look at an acute leukemia, they are characterized by abnormalities in the immature leukocytes, and often on the CBC differential, you will see blast cells. The acute leukemias account for 80% of adult, when they have leukemia, 80% are adults and 20% are children. There is, in general, there is genetic and epigenic changes in the precursor cells that leads to abnormal proliferation, differentiation, maturation, and resistance to apoptosis, which is again cell death. As the bone marrow, continuing just along that, the bone marrow gets crowded, it also reduces the ability for the body to make new erythrocytes, thrombocytes, and other non-mutated leukocytes. Some of the risk factors include radiation, chemotherapy, tobacco, toxins, trisomy 21, HIV, thyroid disorders, obesity, but most times there is no identifiable cause. The clinical manifestations that you might see with a acute leukemia include low blood lines. So you might see what they call pan-thrombocytopenia, which means that the patient has a low blood cell count, low platelets, and low white blood cells. They often present with bone pains, unintentional weight loss, anorexia, splenomegaly, hepatomegaly, or splenectomy. And again, on CBC, they have blast cells that are present. Diagnosis again includes a history and physical, peripheral blood smear. That's where the pathologist actually looks at a sample of the blood underneath the microscope to see the different shapes of the blood. You would also have a CBC and a bone marrow biopsy. The goal is complete remission, and the treatment options include chemotherapy or bone marrow transplants. They also do targeted therapy with radiation, biological therapies, and donor lymphatic infusions. We've come a long way in our treatments of those. There is also a in your class resources, there's a chart that has all these listed out there that is general, that kind of helps summarize all this information. So in chronic leukemias, the tricky thing about these is that the cells, when you look under the microscope, they actually appear to be normal cells, but they function abnormally or not correctly. CLL is the most common type of leukemia in adults, and there's rarely T cell involvement. CLL develops as an interplay between genetics, epigenetics, and the microenvironment. CML depends on the lineage of the polycythemia vera. You might see essential thrombosis or primary myelofibrosis. With these, you also have the presence of the Philadelphia chromosome, which again is one of those questions that everybody likes to ask. So make sure you know that CML is the presence of the Philadelphia chromosome. Clinically, again, it's going to depend on when they present. Generally, they're going to be asymptomatic, but may have more symptoms as they progress. They may have local or general lymphadenopathy, more specifically in their upper body. The CML has 3 phases. There's a chronic phase, an accelerated phase, and then a blast crisis. As the person progresses through the phases, they develop more manifestations. As the CML phase advances, the body becomes less responsive to treatments. Again, for diagnosis, we're going to have a routine blood count and a peripheral smear. The treatment is supportive and basically as needed, and treatments work the best with in the chronic phase, and they often do immunophenotyping and a bone marrow biopsy to be able to use the correct kind of leukemia or biological agent to slow down the progression. All right, that was a mouthful. Moving on to anemias. Before we get started on the anemias, I want you to just mark down to look at table 3.3 on page 98 that talks about the different, the mean corpuscle value, that's the MCV. You'll often hear that talked about, and that table kind of differentiates it all out for you nicely. And there's also a common lab table on page 99, figure 3.4. That's also important to know. Anemia is defined in males as a hematocrit of less than 41% and in females less than 37%. This can be caused for many different reasons. It can be an acute trauma or it can be a chronic kidney disease. Some of the diseases are acquired and some of them are inherited. When we don't have enough oxygen, blood cells, it impairs the oxygen carrying capacity of the blood, and there is decreased red blood cell production or increased red blood cell production. This is classified by the cause of the anemia or the shape of the RBC, which is the morphology. These patients generally present with weakness, fatigue, pallor, syncope, dyspnea, or tachycardic. Again, in general, when we're talking about anemias, we're going to look at a CBC, we're going to do a physical exam. We may also want to do iron studies, as that will help us determine what kind of anemia it might be. Generally, when you're working up an anemia, a bone marrow biopsy is generally not the first. That's generally way down the line if you can't diagnose the problem at all. Most times you can diagnose it before you would actually get to that when you're working on an anemia, as opposed to the leukocyte disorders. The first one we're going to talk about is iron deficiency anemia. It's macrocytic. It is most common in women of childbearing age, children under 2, and elderly individuals. The reason it is common in women of childbearing age is because women often get iron deficiency anemia when they have their menstrual cycle, and in children under 2 and elderly individuals, that's part of just the group that gets it. But when someone does have this, the biggest thing that we want to evaluate for is a gastroenterology malignancy. Absorption of iron is in the upper GI tract. The hemoglobin synthesis diminishes, and the cells are pale and small. So when the iron's not absorbing, it's not helping the acceleration of erythropoiesis to make more reticulocytes. This may be caused by decreased iron consumption, decreased iron absorption, or again, the causes of increased bleeding that we talked about. The clinical manifestations, there are numerous. This is a partial list, and I will add to that that they may have nausea and vomiting, and all the other signs that we've talked about that are someone with anemic. They may have shortness of breath, dyspnea, decreased activity tolerance. As far as the workup, you're going to do a history and physical, and you're also going to do a CBC. You're going to check a ferritin and serum iron levels, a transferritin saturation, a stool for occult blood, and eventually probably a colonoscopy or an endoscopy if they have not had one recently. Treatment is basically if there's an underlying cause to treat it, but basically we want to increase the iron levels, and that is usually done via supplements. We also encourage iron-rich foods, which include liver, red meat, fish, beans, raisins, and green leafy vegetables. Megoblastic anemia is due to a B12 and folic acid deficiency. This is characterized by delayed nuclear development, but normal cytoplasm development. It causes cells to be larger than they should be. Poor oral intake is the most common cause, and that results disorders to think about when someone has this is chronic alcohol use, anorexia, malnutrition from illness. So again, these can be repleted through dietary supplements, and it's important to know that these folks there's two groups of folks that are at higher risk for this kind of anemia, and that is people who've had gastric bypass and inflammatory disorders. So we talk a little bit about how this happens and intrinsic factor and vitamin B12 absorption are facilitated by the pancreatic enzymes in the duodenum. With good dietary sources, including meat and dairy products, that absorption normally happens. When someone has pernicious anemia, which is specifically related to the B12, the autoantibodies target gastric parietal cells with autoantibodies that impair the production and cause destruction of the intrinsic factor in other gastric secretions. This can be seen in people with chronic gastritis, Hashimoto's thyroiditis, Graves' disease, diabetes type 1, and chronic use of a PPI or H2 blockers. Similar to the other anemias, vitamin, as part of the workup, you would want to check a CBC, peripheral blood smear, and also vitamin B12 and folate levels. If you look at your CBC, you'll recognize that you will have a high MCV with low reticulocytes. Your homocysteine levels will be high as well. The treatment is basically oral or IV supplements. And it is also important to know that preconceptual folic acid supplementation is recommended for women planning to become pregnant to prevent neurotubule defects. Anemia of chronic disease is the second most kind of cause of anemia, and that is basically caused by chronic diseases or inflammation. When these are persistent, there's decreased red blood cell production by the bone marrow and shortening of the red blood cell survival. The underlying disease is usually whatever the clinical manifestations are secondary to whatever the underlying disease is. When you are diagnosing this, again, you want to check a history and physical, a CBC. You will see mild to moderate anemia, a low reticulocyte count, elevated inflammatory markers, and low transferrin. The low reticulocyte count reflects a decrease in the bone marrow production. You'll also see low iron levels. The treatment is to resolve the underlying disorder or anemia. Sometimes we will give iron to these folks, but sometimes it's not well tolerated. So if someone has a toleration issue, I just always recommend slow Phe, which is a slow, it gets absorbed in a different way and is not quite as overwhelming to the system and doesn't cause so many side effects, specifically constipation. Aplastic anemia is when the cells are normocytic. It is very rare, but a serious condition, and I actually have seen one patient with this in my whole career. But basically, the bone marrow fails to produce the multipotent HSC precursors. That leads to pancytopenia. And remember, pancytopenia means everything is low. Erythrocytes, leukocytes, and platelets. All the cells present are mature and normocytic and normochromic. There just isn't enough of them. Causes can include idiopathic causes, which again, we don't really know what, autoimmune conditions. It can be from medication. It can be from viruses or genetic disorders. It can also be from infections, pregnancy, or cancer. They're going to present similar to people that have anemia, leukopenia, and thrombocytopenia. They may have weakness, pallor, shortness of breath, infections, or bruise easily. These folks, no matter how much blood you give them, they will just not make anymore. And the lady that I actually was taking care of one time who had this, she actually had it from a medication. I can't remember the medication right now, but she had to come to the hospital. Once we figured out what it was, she had to come to the hospital every 3 days to get a blood transfusion. And she lived, once we diagnosed it, she lived about 4 weeks. But it was a pretty devastating thing, and she actually didn't want to come to the hospital to get any more blood. So, it worked out the way she wanted to, but it was still a devastating diagnosis because no matter how much blood you give them, there just is no more. Their body just does not make any more. So again, the diagnosis is a CBC and a bone marrow biopsy. The treatment is to treat the underlying causes and treat for any complications. So you want to give them oxygen. Infection control is important, and bleeding precautions. They will also probably get frequent blood transfusions, and the other treatment that may be available to them based on the cause is a bone marrow transplant. When somebody has excessive loss of red blood cells, this could be for a number of different reasons. Usually it's traumatic, it can be during a surgery, but during that, the bone marrow increases production to replace the red blood cells. The blood is normocytic and normochromic. It can also be caused by hemolytic anemia, which means that the blood is destroying itself. That can be caused by genetic, autoimmune infections, or blood transfusion reactions. Remember, lytic means it's kind of killing. Lytic means that the red blood cells are being sliced apart much earlier than they should, which is shortening of the lifespan. Remember, we talked about the normal lifespan is 4 months, so it goes much faster than that. Some of the disorders associated with that are sickle cell disease. This is a disease common in African Americans. 1 in 500 births actually are diagnosed with sickle cell disease. And in the United States, every African American, those born with Southern American or Central America descent, those with Caribbean descent, Middle Eastern descent, or Mediterranean descent are all checked for sickle cell disease at birth. It's one of the most common inherited blood disorders, and it is mutation on the HBB gene. The hemoglobin S changes the shape of the red blood cells, and there's a picture on page 106, figure 315, and it basically, you'll see the cells look sickled or like quarter moon. These cause increased oxygen demand. And because of the shape, there's less room for the blood and the oxygen to attach to the cell. It decreases the surface area. Now, some people are born with the sickle cell trait, which means they actually have no symptoms of sickle cell disease, but do carry the trait. Those with sickle cell anemia, it's inheritance of hemoglobin S from both parents. Because of the abnormal shapes, there's less oxygen delivered to the tissues. They have a shorter lifespan. And these blood vessels, because of the way they're shaped, can cause a vaso-occlusive crisis, which is a medical emergency for them. They are hospitalized and given IV fluids. Sometimes they need pain medicine because it is very painful to have the vaso-occlusive crisis, especially in the periphery. The common sites of the pain are lower back pain, chest, abdomen, and the long bones. Basically, a part of that, they get pain because the blood gets stuck. Part of they're having ischemia, so it's like a heart attack to the peripheral parts of their blood. So the way to get that better is to hydrate them um, and treat their pain. The diagnosis is done through hemoglobin electrophoresis. The triggers of an acute vasal cell crisis are generally fevers, the menstrual cycle in females, high altitudes, dehydration, and infection. When you're doing the diagnosis, you also want to check a CBC, and you also want to make sure you check a reticulocyte count to make sure that's elevated, because if that's not elevated, they can also have an aplastic crisis. So that's something that we definitely want to prevent. We're going to talk next about thalassemia. It's a microcytic disorder, mostly in Mediterranean people. This is abnormal hemoglobin from an abnormal quantity of some proteins in your blood. There's a beta thalassemia, which is the mutation on the HBB gene. And again, you'll often, a thalassemia also it looks like an anemia, so it's some of the same signs and symptoms that we've been talking about. Alpha thalassemia is not as common. Again, it's categorized by the symptoms, and the mutations there are on the HbA1 and HbA2 genes. The clinical manifestations depend on, again, what kind of crisis they're having, either a minor crisis or a major crisis, and that is, again, the same kind of clinical manifestations that we've had. The diagnosis is based on a positive family history and physical exam. Again, you'll also probably have a CBC involved there, and treatment for the severe cases include blood transfusion, chelation therapy, bone marrow transplants, and a possible splenectomy. Polycythemia is when you have normal or increased amounts of red blood cells in hemoglobin. There are two types: primary polycythemia or polycythemia vera. You also have secondary polycythemia and relative polycythemia. You can see this in, sometimes we don't know why it happens, but sometimes you can also see it in people who have untreated obstructive sleep apnea is a common place to see it. These folks will have visual disturbances, high blood pressure. They may have a large spleen. They may have pruritus or an itch after coming in contact with water. And they may have vasomotor or microscopic vascular thrombotic changes, cyanosis in the fingertips. This is checked with diagnosis by a low serum erythropoietin and a peripheral mutation of the JK2. So that would be done through a serum electrophoresis. Treatment for this is chemotherapy or reduction. This is where you may hear something called bloodletting, where they let some blood drain out of people. We still do occasionally do that. They used to do it a lot in the early 1900s, but we still do that once in a while. Iron overload results from the increased intake or absorption. There are The one group that we can see this in a lot is in people that need frequent transfusions, specifically our sickle cell patients. And basically, when there's excessive iron, it saturates the transferritin and there's iron binding to other proteins. It is absorbed by the cells that transform into iron and a reactive oxygen species. There's too much iron gets in the blood cells. The clinical manifestations are generally nonspecific and develop very slowly. And once it is evident, there's usually end organ damage. How we diagnose this is by checking iron levels. There'd be a high iron, high ferritin, and high transferritin saturation levels. There would be a low iron binding capacity and an iron deposits visualized by MRI. This can be treated to prevent end organ damage with phlebotomy and chelation therapy. Thrombocytopenia is when there is a low platelet level. It puts these folks at high risk of bleeding. It can be a life-threatening condition. When the platelet counts get below 15,000, that usually results in or puts them at high risk for spontaneous bleeding. This means that basically there's a decreased production or increased destruction of the platelets, and how we would determine this is by doing a medical history, and we'd also check a CBC to see the cause of the platelets going down. This can be caused from a few different things. Immune thrombocytopenia is a hypocoagulable state where the immune system is actually destroying its own platelets. There is a secondary ITP causes, which is related to autoimmune disorders, immunizations from live vaccine infections, and cancer. Primary ITP is the most common cause, and it can be either acute or chronic. These patients are often asymptomatic, but you may see them have abnormal bleeding. The diagnosis is usually a diagnosis of exclusion, because sometimes it's hard to know exactly why this is happening, but the management is basically to increase the platelet count and prevent or manage severe bleeding. Anytime that platelet count gets below 15,000, your patients are at very high risk for bleeding, so they're probably in the hospital if it's that low. Thrombolytic thrombocytopenic purpura is a coagulation disorder. There is a deficiency in the enzyme necessary for cleaving of the von Willebrand's factor. There is a increased clotting and decreased availability of platelets. This is characterized by microthrombi in the microvascular vasculature, thrombocytopenia, and bleeding. The clinical manifestations of this include, again, looking for signs and symptoms of bleeding. This may be something that comes on quickly or is insidious, and it involves multiple systems, which means typically it's the neurological, cardiovascular, and GI system. For diagnosis of these patients, you may see checked a high HDL and a reticulocyte level. You'll also see obviously a CBC. And the treatment for this, I've actually seen one person with it. They have like little purple dots all over their skin. And the treatment for this is plasmapheresis. And plasmapheresis is basically they get hooked up to a machine like a dialysis machine, but instead of filtering out the waste like you do during dialysis, you filter out the parts of the blood that you don't want there. So they try and remove the things that they don't want there. Thrombocytopenia is an increased blood cell count. These platelets pool in the circulation, and that can be after splenectomy or in response to infection and inflammations. Sometimes, if someone has been very septic, they may get a very high white blood, a very high platelet count. So they have to stay on aspirin until that platelet count comes down. But it really depends on the cause and how you treat it. Primary thrombosis, it can also be from a myeloproliferative neoplasm. So it's important to kind of rule out why they have it. But that would probably be done by a hematologist. You just kind of need to know if you see a high white blood cell count, it's something that you'll need to further investigate. We're going to go through a few other diseases. We're going to talk about hemophilia first. When you're reviewing these, just know that hemophilia A is a deficiency of clotting factor 8, and hemophilia B is a deficiency of clotting factor 9. These are generally manifested by bleeding, petechiae, bruising, GI bleeding, or hematuria. If you suspected this on someone, again, you'd refer them to hematology, but it's just as important to know that what factors are low, and know that it would need to be further worked up if you have someone that was bleeding and you didn't know why. The diagnosis is made by examination of bleeding studies, and the treatment involves replacement of clotting factors and bleeding precautions. So practical advice would be, if you had a young child who was diagnosed with hemophilia, you wouldn't let them play contact sports because you want them to have spontaneous bleeding. Von Willebrandt's disease is the most common hereditary bleeding disorder. There are 3 different types. It manifests as abnormal bleeding. I can tell you that it is often manifested in females when they start their menstrual cycle, and it's very long. I actually had von Willebrandt's disease and was diagnosed when I was preparing for a surgery. Luckily, it is just treated when I need surgery and doesn't cause a big problem in my life. But if I ever do need surgery, you need to have some cryoprecipitate infusions or desmopressin prior to treatment. They now have Humate, which is a synthetic clotting factor that they can give to control the bleeding. And basically, bleeding, it is control of bleeding is the most important thing. And the diagnosis and how you treat it really depends on the severity. But again, if you see a female who's got a very long period, this is one thing you want to think about with them. So disseminated intravascular coagulation. This is something that is very rare. These people usually have some kind of life-threatening disorder. They're in ICU. They have multi-system organ failure. And you're going to diagnose this through a CBC and coagulation studies. It is complicated because these folks are prone to peripheral clots, but central bleeding. Pardon me. Again, you're not going to be treating this, but if you are working in a situation where you have someone who's been very sick and has some bleeding that you can't explain, this is one thing that could, but they're often very sick in an intensive care unit. So finally, thrombophilia is a state of decreased coagulation. It can lead to the tendency to form DVTs, or the venous thromboembolism. There is often an antiphospholipid syndrome. You may hear this as factor V Leiden deficiency. And so basically, they form clots much more frequently than we do. So when people have DVTs, this is one thing that we often work up for them if we can't find a cause for the DVT. And the treatment depends on the risk for thrombosis. If it is bad enough, sometimes they stay on an anti-clotting medication for quite some time. But again, important for you to know that if you do have somebody who's had a blood clot, you'll need to work them up for some thrombocytopenia, which you'll learn more about as part of their workup to prevent further clots. So that brings us to the end of this slideshow. I hope you have enjoyed the lecture. And if you have any questions, please be sure to let me know.